Welcome to our discussion on bilevel ventilation. This is, for most people, a new and oftentimes very confusing topic. I included a bunch of pictures and text for all of you people, again, who don't like to read. But ultimately, this is a required training if we want to have new toys to help our patients. This is being brought to you by the Harford County Department of Emergency Services Training Division. We do our best to work for you, so please never hesitate to reach out with suggestions, requests, and edits so that we can bring you the best, up-to-date, and most relevant content. Understand that a lot of time and research goes into these trainings, but we can't do it without you helping us start with a question worth answering. We are happy to leave our contact information at the end. Okay, quick housekeeping item. We are not paid to endorse any specific brand or product. I wouldn't complain if they did, but they don't. Always consult your protocols and follow the advice of your medical director. Device performance depends on setup, supply, and patient factors. Always operate within your scope of practice, licensing requirements, and documentation standards. So do you remember this lady? If you don't, you probably didn't watch our previous videos on CPAP. Or if you did, you might have ADHD like I do, so I would go back and rewatch that first one before continuing. This lady was a respiratory case where she was found in hypercarbia, or a type 2 respiratory failure. She was solved by low amounts of oxygen, but some PEEP from a CPAP mask is really what she needed. But let's just say this time she takes a little bit of a turn. CPAP has its place for sure. It especially works for the type 1 hypoxic patient who needs oxygen to get to the tissue, but can't because fluid, snot, phlegm, lung butter, or whatever else is in there. PEEP is extremely useful to expand and recruit the alveoli that are otherwise not available to take corrective action on applicable heart failure by reducing preload and reducing afterload to the lungs and the body. First major point is to evaluate the patient's breathing status. Does the patient need a little bit of coaching? Is it possible that you have the PEEP set too high? Before she rips the mask off and you generally suffocate this patient, have you considered backing the PEEP off to a tolerable amount? Is the patient too tired to keep up with that added pressure? Don't forget to recycle the blood pressure because this is a cardiac machine and it can have significant effects on the patient's hemodynamic status. BiPAP isn't CPAP but better. It's a different physiology, different risk profile, different logistics, and a lot of the time CPAP is the clean and fast and safest move. The BiPAP is what you escalate to when CPAP isn't enough or when you're treating ventilatory failure. For those type 2 respiratory patients, they are the ones who will likely benefit from the use of bilevel ventilation. This is where we may see the largest impact in our patients. BiPAP adds ventilatory force you may not need, and that extra force could increase the risk of aspiration. If you suspect a pneumothorax, this could be the thing that tips them over. It also increases the chance for hypotension and barotrauma in fragile lungs. So if they're oxygenating but failing, but they're ventilating okay, then bilevel may be more intervention than necessary. A few more definitions that we should probably touch on. Firstly, BiPAP is a registered trademark of Respironics, so you'll often hear this word interchangeably. That said, BiPAP is a non-invasive ventilation with two pressures, your inspiratory and your expiratory airway pressures. Your EPAP is often interchangeably used with PEEP since it functionally is the same. It is the expiratory maintained pressure that helps increase your functional residual capacity between breaths. What we are adding to the vocabulary is IPAP. Think of this like bench pressing weight. PEEP, or EPAP, is the continuous pressure throughout the whole breath. This is just a little different than just those spring PEEP valves. On ventilators, it's turbine driven, more like your head out the window analogy. You're not getting an assisted breath, just a continuous pressure that you must breathe against. With IPAP, this is help with the lift. This is like using a BVM to give support for someone who can't breathe effectively on their own. When the patient initiates a breath, there is assistance with that lift. Pressure is given to help inflate the lungs, at which point pressure is lowered to allow for the exhale, but not enough to let the alveoli completely deflate. So again, EPAP sets the baseline and IPAP sets the peak pressure to help reduce the effort of breathing. Pressure support is the ventilatory difference between the two values. More on this when we discuss ventilators in a future video. For now, we can keep it as simple as possible. Applying this new CPAP device is actually quite easy. The mask has convenient quick clips and an adjustable pad for the forehead for comfort. Remember to allow the patient some time to acclimate to this new mask feeling to avoid some panic or claustrophobia. Now on the oxygen tubing, you're going to notice the oxygen flow setting. Set the O2 bottle liter per minute to correspond with the desired PEEP value. There's no spring device to set the PEEP. Using the manometer, you verify that you've achieved the desired PEEP, and then you would just adjust the oxygen flow regulator as needed. Now switching to bi-level, now that's almost firefighter proof. You just flip the little blue switch on the front of the device on the oxygen tubing. On the opposite side of the blue paper is the EPAP settings. Again, this is very similar to your PEEP. So you're going to verify the EPAP on exhalation. You're going to adjust your IPAP with the little blue knob on the side of the device, or in this case on top. And that's it. That's right. Some of you think, but wait, don't I need a transport ventilator? We found this device. It's called the FlowSafe 2 Plus. It's a completely disposable device. It's simple to use. It operates off of low pressure flow and works well with our current equipment. I actually really like the way that this mask works out. So this is kind of nice because you actually have these quick connect clips, so it allows you to like take the mask off and then bring it around. What's also nice, especially nice, is this right here. This allows you to actually raise and lower the head pad. The pad is a little bit odd. Sometimes you'll find it come out of the packaging where it's already kind of like snapped off. You'll see, if I can get it on the camera there, you'll see there's these little hooks. It just lines up in here and comes back together. But this is actually really nice because it helps to get the mask off of the patient's nose rather than looking like it's smashing up into their forehead. So the adjustments on this are really nice. I would definitely take some time to take a look and take some time to look it over so that it doesn't look like you're fumbling it. But the straps all tighten individually and it has a nice head mesh. So now what? What should our settings be? Where should we start? With bi-level devices, a lot of them use different terms and parameters to set the pressures. Some, they set the pressure by pressure support, and others they set by desired tidal volume. With the disposable one we have pictured here, we'll be setting the IPAP and the EPAP. So when describing or documenting this, we will say inspiration over expiratory. So for example, in our protocol here, we will be setting the EPAP to 5 centimeters of water and the IPAP to 10 centimeters of water. That would be said 10 over 5. Now this would max out at 15 over 8. And to be clear, let's be sure to state exactly what you are setting. So when you're transferring your patient to respiratory, they could infer the first number being pressure support or peak inspiratory pressure rather than inspiration positive airway pressure. The lingo may change depending on your system. Without some fancy expensive ventilators, we will need to make the adjustments in small increments and work with our patient if you think that increasing these initial settings will help. So you'll be, for instance, increasing the EPAP when the problem is with oxygenation or airway collapse, and you're going to increase the IPAP when the problem is ventilation, the CO2 or work of breathing problem. So for instance, with your type 1 patients who need some more oxygenation, increasing your IPAP helps with the patient who is looking exhausted, taking shallow breaths. They have poor chest rise. You could increase every 2 to 3 for every maybe 15 minutes as tolerated. Your EPAP would stay the same unless oxygenation or obstruction is present. For your type 2 hypercapnic patients, your EPAP helps you when your SpO2 is low despite adequate FiO2. So you might have atelectasis or shunt type hypoxemia. You could also have this for your COPD patient with an auto-PEEP symptoms like pursed lip breathing. Capnography is important in your assessment because they may have CO2 retention, and acidosis, where recruitment is important. For this, your EPAP could be increased 1 to 2 centimeters of water every few minutes as tolerated. So in the simplest terms, EPAP holds open the alveoli for gas exchange, and IPAP fixes volume and effort. As with other devices, don't forget that you can still use this with inline nebulizers. It's very simple. They just snap right in using the standard T-piece. End-tidal CO2, however, I would recommend that you use the nasal prongs, getting it a little closer to the patient's face rather than putting it inline using the end-tidal, the ET version of it. I will say, though, that there are these two little black nipples on either side. After talking to the manufacturer, they said that this was really important to the European communities where they wanted to add extra FiO2. And it brought up a pretty good point. If you did need to increase your FiO2 beyond what this mask is giving, there's a pretty simple way to do it. Remember, we can use a nasal cannula to add extra oxygen inside the mask, but if you use standard oxygen tubing or even a nasal cannula or non-rebreather and you snip off the ends, these actually can be fit over top of those nipples, and then it allows you to pump extra oxygen into the mask to increase your FiO2 beyond the 65 to 75% that you're getting. All right, this is it. You can wake up now. This is the last slide. So this is going to summarize everything I just said since you fell asleep along the way. BiPAP does two different jobs. There's IPAP and EPAP. EPAP is for oxygenation. That recruits alveoli, improves gas exchange, similar to CPAP. The IPAP, or inspiration, is more for ventilation. This helps move air in and out. It reduces CO2, and it helps offload the work of breathing. Easy to remember, EPAP fixes oxygen, IPAP fixes ventilation. BiPAP reduces the work of breathing. So patients who are in respiratory distress are often exhausted. BiPAP helps by assisting inhalation, keeps the alveoli inflated, reduces accessory muscle use, improves tidal volumes, and this often results in a lower respiratory rate, improved oxygen saturations, and improved mental status. BiPAP is ideal for certain patients. The best evidence supports BiPAP for COPD exacerbation, where they are hypercapnic, air trapping, and fatigued respiratory muscles. Your CHF and pulmonary edema, it's great for recruiting flooded alveoli. This decreases preload and afterload. And then moderate respiratory distress patients before the patient crashes. BiPAP buys us time. In EMS, BiPAP is often a bridge therapy. It can prevent intubations, it improves patient comfort, it stabilizes the patient for transport, and it gives medication time for it to work. Many patients who receive BiPAP, they never earn a tube, so it's great for us in the pre-hospital world. But just know when BiPAP is not appropriate. BiPAP requires cooperative patients. If they are showing a decreased level of consciousness, if they are vomiting, facial trauma, severe hypotension, or the inability to protect their airway, this is not a patient that this is good for. Also, if the patient is not able to tolerate the mask, it's not going to work. So a simple way to explain the settings, a common starting point is 10/5, where 10 is the IPAP and 5 is the EPAP. Pressure support would be 5. Remember, it's the top number minus the bottom number. Increasing IPAP would improve ventilation, and increasing the EPAP improves oxygenation. So, field assessment. Within 5 to 10 minutes, you should hopefully see improvements. You're looking for lower respiratory rates, less accessory muscle use. We're looking for improved pulse oxes, improved end-tidal CO2. Patient should look more comfortable, and if the patient is worsening, we should reassess. For more information, contact your training division.